We shall discuss about the anatomy of axilla. The axilla is a fat-filled, truncated pyramidal-shaped space. It has got an apex, a base, and four walls: the anterior, posterior, medial, and lateral walls. The apex is triangular in shape. It is also called as a cervico-axillary canal, and it is bounded anteriorly by the posterior border of clavicle, posteriorly by the upper border of scapula, medially by the outer border of first rib, and laterally by the coracoid process. Axillary canal forms the apex of the axilla. It is directed upward and medial and continues into the root of the neck, carrying various structures in and out of the neck. The structures passing through the cervicoaxillary canal includes the axillary vessels and the cords of the brachial plexus. Both of them are covered by axillary sheath as they pass through the cervicoaxillary canal. The axillary artery and the brachial plexus enters the axilla from the neck, and the axillary vein enters the neck from the axilla through the cervicoaxillary canal. The cervicoaxillary canal is bounded anteriorly by the clavicle, posteriorly by the upper border of the scapula, and medially by the outer border of the first rib. Now coming to the base or the floor of the axilla, it is formed by a thick layer of axillary fascia as well as skin. When the arm is abducted, the floor becomes concave due to the pull of the suspensory ligament. It is bounded anteriorly by the anterior axillary fold, posteriorly by the posterior axillary fold, and medially by the chest wall. Coming to the boundaries or walls of axilla, the axilla has got four walls: anterior, posterior, medial, and lateral. The anterior wall is formed by the pectoralis major muscle in the whole extent, pectoralis minor muscle, the subclavius muscle, as well as by the clavipectoral fascia and the suspensory ligament of axilla. The posterior wall is formed by the scapula, the subscapularis muscle in the upper part, the teres major muscle in the middle part, and latissimus dorsi in the lower part. Coming to the medial and the lateral boundaries of axilla, the medial wall is convex. It is formed by the upper five ribs as well as the intercostal muscles in the upper four intercostal spaces. There is also serratus anterior muscle from its upper four or five digitations. There is also nerve to serratus anterior or long thoracic nerve, as well as the intercostal brachial nerve, which forms the medial boundary of axilla. The lateral boundary is formed by the convergence of the anterior and posterior wall. It is formed by the upper part of the shaft of the humerus, where the bicipital groove is there. Through this bicipital groove, the long head of biceps brachii passes. The lateral wall also has got the teres major muscle, which forms the posterior axillary fold, and also coracobrachialis muscle. All of them forms the lateral wall or boundary of the axilla. There are 8 contents of axilla. The first one is the axillary artery and its 6 branches. Then we have the axillary vein and its tributaries. Next up, we have the infraclavicular part is the brachial plexus consisting of the 3 cords and the 13 branches. We also have the long thoracic nerve or the nerve to serratus anterior, intercostal brachial nerves, the axillary group of lymph nodes, the loose areolar tissue with axillary pad of fat, as well as the axillary tail of spines. The medial and the posterior wall of axilla have bones which are covered by muscles. The lateral wall is also bony. Only the anterior wall is devoid of bones and it is fleshy and covered with muscles. The base is also facial, which is covered by axillary fascia. So any surgical approach to axilla is usually through the anterior wall or through the base. The usual surgical procedures of the axilla are the drainage of axillary abscess or the removal of an axillary lymph node. Now coming to the clinical anatomy of axilla, the first one is the dislocation of shoulder. The dislocation of shoulder can result in damage to the neurovascular structures in the axilla. Especially in case of inferior dislocation, there can be injury to the axillary nerve. Lymphadenitis is the inflammation and enlargement of the lymph nodes due to an infection or carcinoma. Axillary lymphadenitis can be because of an infection or malignancy of the upper limb, breast, or abdominal wall above the umbilicus. Yet another applied anatomical aspect of the axilla is the paralysis of serratus anterior muscle. The long thoracic nerve which supplies for the serratus anterior muscle is the content of the axilla. The compression of the long thoracic nerve, which is also called as the nerve of Bell, by enlarged central group of axillary lymph node, can result in the paralysis of serratus anterior muscle. Yet another applied aspect of axilla is the thrombosis of axillary vein, which can lead to venous stasis and edema of the upper limb. Thrombosis of axillary vein can occur because of hyperabduction of the arms for a long period of time. It can also be a complication in the post-op of radical mastectomy with removal of axillary lymph node. The thoracic outlet is a space in between the collarbone of the clavicle and the first rib. The thoracic outlet is a narrow passageway and it is crowded with blood vessels and nerves. Thoracic outlet syndrome happens because of the compression of these vessels and nerves in the axilla. That is, the vessels in the nerves will get compressed in between the clavicle, the first rib, and the scapula, which leads to various symptoms. And these are together called as a thoracic outlet syndrome. Thus, we have covered the major anatomical points with respect to axilla. Hope it was helpful.